I'm not used to speaking in 15-minute increments, so I will do my very best to try to get through my task, which I think is how do you get paid for this particular service. Before I get going, take your pencils out because probably I am going to go very quickly, and you want my email address, because if you want a copy of these slides, I'm more than happy to send them to you because I'm going to go over them very quickly. Okay, so there's my email address. Feel free to go ahead and email me, and my disclosures are up there as well. So I'm responsible for covering coding, coverage, and payment, plus prior authorization in 15 minutes. So everybody hang on, here we go. Here are your procedure codes. The one thing that I would like you to take away from this is notice that I have an unlisted code up here. I also have a code that's a G code, G0235. G0235 is Medicare's way of having a way to track a procedure that's not covered. So that's tip number one. Tip number two, code 78499 can be used for procedures that don't have their own code. So when you hear some of these speakers talking about flow reserve, you hear the speakers talking about wall motion and ejection fraction for cardiac PET. Those do not have their own CPT codes. And if I can have one takeaway message from this talk, I'd like you to know that what I personally need in order to get you paid for these procedures is I need tracking. And whether or not you actually get paid for some of the services, what is critically important is that you tell the payers what you are doing by using these codes. So 78491 and 92, that's your single study and multiple studies. But notice they're not the same as the spec codes. They were created a while ago. And so we do want you to code and bill for all the different items so that the payers understand what you're actually doing. I don't have the cardiac CTA codes up here, but I can send those to anybody. So the last presentation, we saw the radiopharmaceuticals. I'm primarily just going to talk about these three here. So we do code and bill your radiopharmaceuticals separately. And there are some tips. You have to watch the descriptions very carefully. These are per study dose. So a single study is 1, multiple studies is 2. You don't get to call that scout scan that you saw as another dosing. So don't try to code and bill for 3 units. The typical is 2 or 1 based on whether or not you're doing a rest only or a rest and stress. Don't forget you're stressing this patient. Unlike the echo codes, we don't bundle in our stress test code. So it is coded and billed separately. That's one of the things that when I audit sites, we see missing on claim forms. If you're in the hospital setting and you're doing just the stress tracing only, that's the 93017 code. Don't forget your farm stress agent. You got to code and bill for that. I have to tell you, when I code and when I do audits for sites, the primary thing that we see are missing radiopharmaceuticals, missing number of units, missing drugs that are on these claims that are going out to payers. So I refer to it as a charge master alert. Make sure that the correct units for the description are going out, as well as the codes on the claim form. We have some new policies that are coming into play. The JW modifier is going to be a requirement from Medicare. It had been voluntary for many years. They tried to implement it on July 1st and got a lot of pushback, so it's now going to be implemented on January 1st as a mandatory requirement that if you are trying to code and bill for a wasted product, and that would be not using an entire vial of adenosine is a example of that, because that's a single-use vial, then you are going to be required to append the JW modifier for anything that you're billing that's a wasted product. Don't have time to get in details on this, but I can certainly talk offline to anybody who has questions about those particular items. If you're in the hospital setting, you do need to report revenue codes as well, and that becomes important for tracking in the hospital setting as well. So do make sure that you have all the codes that are correct, that match with the procedure. The next most important thing is your documentation, and I'm just going to go over some basics here. I won't read you the slide because you can read them yourselves, but the key point takeaway message here is don't assume that anybody who's reading your report knows what you do. So make sure that you're very clear and try to stick with the CPT language whenever possible, because you're going to have an auditor or a coder or a biller who's going to take your words and have to turn them into code to then send them out, as well as you're going to have somebody who has a high school diploma who's the auditor and works for a payer, who's then going to have to determine whether or not you properly documented your particular studies. So in PET studies, we have a national coverage decision. Most of us in the payer world really only have to deal with local coverage policies, but for PET, you have to deal with the NCD. We only see that in 10% of the studies. You actually have to look at not only your national coverage policy, but your local policy. Luckily for our myocardial perfusion imaging PET, we have a positive coverage decision as well as for viability. So that's a plus for us. We will see, and you will see, local coverage policies, but I'm showing you here, if you're going to perform these studies, whoever's coding and billing needs to pull down that 220.6.1 and make sure that they have the national coverage policies in their department so that they know what the coverage policies are. Then the next thing you want to do is find out who your payer is, and you want to go to their website and find their local coverage policies, and I'm going to show you a few examples here. So this is the national listing. You can go right on board and pull up your local coverage policy for your particular region. For those of you who haven't seen them before, I'm going to show you a couple examples. If there's not a formal LCD, local coverage determination, sometimes the payers call them an article, and the reason they call them an article is because then they can change the article whenever they choose to, as opposed to going through their very rigorous LCD requirements, which means there's a public comment period. So sometimes you'll find the articles, it as an article as opposed to an LCD. And this is an example of what it's going to look like. It's going to say the CPT codes, the 78459, the 78491, and the 78492, and then the list of what's they considered covered ICD-10 diagnosis codes. So you'll be able to see what's covered and what's not covered. Most of the local coverage policies we do find will follow the ACC appropriate use criteria, so that's a good thing. But the other thing that I'd like you to know is when a payer doesn't follow the appropriate use criteria, don't just lay down and give up on it. Go back and fight. Use your own clinical data. Go and have conversations with these particular payers, because they just may not understand the data well enough, and you should be going back in with the documentation. So here's where I'm going to talk a little bit about prior authorization and a little bit about claims denial, or if you're audited, because all of this can be helpful in all of these different scenarios. So I'm kind of merging it all together here for you. Go and pull all your resources, and you'd be surprised how many references there are out there for you. You want to get your national coverage determination, you want to get your local policies that we just talked about. Your local providers have educational sessions. They have teleconferences, they have webinars, they have days where you can go and spend an entire day just with coding and billing folks. And I can tell you that those are the most beneficial, because then you get to talk to the educators one-to-one. So when there's a problem with a payment on your end, you actually have somebody individual that you can talk to or email with. So it can be very beneficial. Go to your specialty societies, go to your ASNC website, your ACC website, the Society of Nuclear Medicine. They all have references for you, and I'm going to show you them very quickly. Dr. Bateman was gracious enough, and he already showed us the next reference that I have, but you do want to go grab the ASNC model coverage policy. That has a list of what ASNC believes are acceptable ICD-10 codes, as well as the old ICD-9 codes, and we tried to link them to the appropriate use criteria whenever possible. So you would have that. We also, you want to grab the ACC multimodality AUC, and then you saw earlier in the earlier presentation the position statement, because that also can be extremely helpful. And what's really helpful in that position statement is not only what it says, but some of the references that go along with it. So as you're, I knew I wouldn't have enough time, and I knew Dr. Bateman would be showing you all those slides, so I just wanted to mention that use that as a resource when you're talking with your payers. Additionally, what's really important when you're talking with your payers is to bring it down into a small, don't hand them the entire appropriate use criteria, don't hand them the entire article. Pull out an excerpt of that and why it's important for the particular patient. For instance, I'm showing this one particular table or chart that if you have, you're trying to do something for a follow-up because something has worsened and you want to make a statement. Pull out the table and put it in your letter when you're sending that for either prior authorization or because you've gotten a denial on the other side. Use all of your references and use the best ones, because know that you're going to have somebody with a little bit of a limited attention span and wanting to get through a lot of paperwork that they have to get through. And so trying to succinctly tell them the story of the patient and why it fits with all the literature and what the societies say is going to be your best avenue. Don't forget the website. It has changed a little bit, so I like to guide you to practice resources and guidelines, and advocacy is where you're going to find most of the coding and reimbursement materials. Notice you can see the reimbursement is under practice resources. And then you can see that you've got some payment tables, and you've got the model coverage policy. So ASNC tries to link things easy for you to get to those resources. Okay, so some tips on the medical necessity letters. The first slide here is just some really basic information that you would be really surprised if I do an audit and I look at a letter that went to a payer is just missing. So want to make sure that all of this is on a piece of paper for you. There are what's called a redetermination request. So there are formal requests to go through the Medicare process, and then there are less formal requests. But when you do submit for prior authorization, there are times where you can initially get a denial, but that denial is not in a peer-to-peer situation, and so you want to be able to supply additional information to a physician. Some prior authorization tips. You want to make sure that you have all of the pieces of information together, like I mentioned, succinct. You want to have your authorization timely. One of the things that was mentioned earlier was knowing your patients and knowing on the inpatient side, you're not going to be going through a prior authorization situation because the patient's an inpatient, that's going to be paid under a DRG. So knowing what situation you're in. The most important thing is that your chances for success for overturning a negative denial can actually be quite high if you pull everything together and you give them the literature that goes along to support what it is you want to go forward. And then this next slide, again, it's wordy because I didn't know how much time I was going to have to present, knowing I was the last presenter here. And so I wanted to make sure you had all of my tips directly. But really your attitude, and I hate to say it, but you've got to play the game, you've got to be nice. You are not going to get anywhere if you we know it. We know your time is valuable. We know it's annoying to have to get on a conference call to try to argue that this patient is an appropriate patient. But the more that you do it, and the more that you're reasonable and succinct, the better off you are going to be for actually getting a successful result. So I know I'm blinking here already with red, and I sort of anticipated that was going to happen. So the next slides are really quick, and they're just the payment rates. So this is the physician office setting for the different codes. You are paid separately for your radiopharmaceutical in this particular setting, so don't forget to make sure you're getting paid for those. You're probably going to be paid mostly on invoice cost. And then this is the hospital outpatient setting. I showed the 2016 as well as the 2017 payment rates. And so with that, I will stop.